My vision for treatment of CLL and broader for medicine and hematology is to have what I would consider data-driven art, data-driven medical art. That during med school, during our training as physicians, we use our knowledge and all the experience we have when we sit in front of a patient to decide what would be the optimal treatment for this patient. That's essentially what we consider medical art. Now we get so much more data from our electronic health record systems in terms of routine data, in terms of genetic analysis, that we cannot have the full overview of these data for the patients, and we cannot identify the patterns. So that's what we try to do with the CLL Treatment Infection Model, to help the physician identifying the patterns that might identify subpopulations of patients with CLL at higher risk of infection or early treatment need upon diagnosis of CLL. And what we have done after that is we don't just want to publish a model that has been published some years ago, we also want to impact on clinical treatment for patients with CLL. And to do that, we needed to implement the model into the electronic health record system, and we needed to test in a clinical trial if we could actually use the information from the model as decision support to actually change treatment. So we implemented the model into the PreVent-ACaLL trial, and what we're presenting here at the EHA meeting is the first data from patients tested by the algorithm prospectively in an international investigator-initiated trial, the PreVent-ACaLL trial, and we report on the patients who were not randomized in the trials. And the trial was designed only to randomize patients who were high risk for infection or CLL treatment. That means more than a 70% risk of either having a serious infection or receiving CLL treatment within 2 years. And among those patients, actually half of the patients assessed by the algorithm to be high risk, high confidence, they refused to go in the randomized part because they didn't want to be assessed as high risk by an algorithm and go to have more frequent follow-ups at the hospital. So that's one of the obstacles working with a data-driven medicine. But now we have the data following these patients, and we started the trial just before the COVID pandemic, and we didn't train the algorithm on during the COVID pandemic, so the algorithm was not trained to identify infections upon COVID. But what we saw is that the model is robust. Both if we include COVID infections and if we exclude COVID infections, the model can perform good in this prospective validation within the clinical trial and identify the patients with a higher risk of a serious infection or CLL treatment and the ones with a low risk. Thus, we don't know yet if the intervention, the combination of acalabrutinib and venetoclax for 3 cycles, very short treatment, not to cure CLL, just to turn CLL back into a more indolent state with a good function of the immune system and less risk of infections. We don't know if that works or not because we're still just in the middle of the trial. But we know now that the model can actually also in a different period with COVID infections identify patients at high risk of infection and high risk of needing CLL treatment.